My name is Colleen Cebulla. I'm an ocular oncologist and vitreoretinal specialist at Ohio State University. And I would like to say it's such a great honor to be invited to speak here today. This has been a superb meeting, so it really means a lot to me. Can you hear me okay? Okay, so I'm an ophthalmologist, so I'm going to talk from the ophthalmologist perspective. When I talked to Grant about this talk, he said, talk about kind of uveal melanoma 101. So I'm going to give you some information, and hopefully we'll answer a lot of questions, and I'll be happy to take some questions after the talk as well. I have no financial disclosures or interests here. And so of course I'm going to talk about uveal melanoma, which is the most common primary intraocular eye cancer in adults. And in terms of an outline, first I'll talk a little bit about what is eye melanoma, which I'm sure are quite familiar with. I'll talk a little bit about epidemiology of it, symptoms, diagnosis, what is a nevus versus a melanoma, what we kind of do for workup and treatment options, and of course oncology monitoring, which is really important. So what is uveal melanoma? Well, this is a cancer of the uvea. So in this picture here, you can see all the black is actually the uvea of the eye. So we can have the iris, which is in the front part of the eye, the ciliary body, which is kind of in between, and the choroid, which goes along the back of the eye. And basically, this is an area where we have a lot of what are called melanocytes. So those are cells, we have them also in our skin, and they usually provide some pigmentation. And that's the type of cell that can become cancerous, becomes a melanoma. This area is very important because it's actually a blood vessel layer of the eye. It's a good way to think about it. So that's a very vascular area. So if eye melanoma does spread, that's the way it spreads, is through the blood vessels. And these are just some of the areas, again, showing where we can have uveal melanoma affecting the iris, the ciliary body, or the choroid. There's additional melanomas that can affect the eye or around the eye, and that can be on the conjunctiva. You can see the very front part of the eye. It's a little bit more like a kind of like skin melanoma in this behavior. You can also have a melanoma of the eyelid, which of course is a type of skin melanoma. So those behave a little bit differently. I'm going to focus more on the uveal melanoma here. So what about epidemiology? Well, it is the most common cancer that starts in the eye, and unfortunately it is a rare cancer. Fortunately, it's rare. It's about 6 per million people in terms of the incidence. And the median age when it presents is typically age 55. Of course, it could present earlier or later. What are some risk factors for eye melanoma? Well, one of them is lightly pigmented people. The white race is much more susceptible to this than blacks or Asians. So we see a much higher incidence of this in that people with that background. Also, people, as they get older, there's a higher risk for developing eye melanoma. So when I talked about 6 per million, that was an age-adjusted incidence. When people get up to more about over 65, the incidence is about 25 per million. Environmental exposure. This is a great question we get asked a lot. What about sun exposure? Should you be wearing sunglasses? So this is kind of controversial, but there seems to be very weak evidence that sun exposure does anything to make eye melanoma worse. Okay? But there are some benefits to wearing sunglasses because that skin, the eyelid melanoma, certainly, or other eyelid cancers could be reduced by wearing that. I think one of the most important risk factors are what we call melanocytic conditions. So if people have a choroidal nevus or nevus of the uvea somewhere, sometimes people will have pigmentation or increased pigment in the skin around the eye, or maybe an atypical mole syndrome, so many kind of atypical moles or even melanomas on the skin. So those people are at higher risk for eye melanoma. At our institution, especially one of my colleagues, Dr. Abdelrahman, is very interested in cancer genetics and family history. And so I think this is something that's a little bit underlooked by a lot of ocular oncologists in terms of the importance of a family history and family connection. So what Dr. Abdelrahman found in a study of 121 patients with eye melanoma, about 11% of them actually had a very high incidence of cancer in the family. So it suggested that they had a kind of a cancer syndrome in the family. And what was interesting, it was not just eye melanomas, it was actually a wide variety of cancers. So that was something that, it is important to do a good family history as a doctor, but also as a patient to get regular cancer screenings, such as colonoscopy, mammography, etc., at the recommended times. And in that study, we found that skin melanoma was the most associated cancer with eye melanoma. So what we're recommending now is that people get a dermatology evaluation at some point just to check for any atypical areas on the skin. So what are the symptoms of eye melanoma? Well, most commonly, there are no symptoms at all, which makes it a very scary thing. Sometimes we can have some symptoms like flashes of light, floaters, maybe some decreased or distorted vision, a shadow in the vision, sometimes a brown spot on the eye. So how do we diagnose this? Well, as we talked before, having a dilated eye examination is really the main way that we can detect this. And the American Academy of Ophthalmology recommends that all adults get a dilated eye examination by age 40. So everybody needs a dilated eye examination at age 40. Very, very critical. So not only do we have problems like eye melanoma, but there are many other silent blinding conditions that we can detect, like glaucoma, problems with diabetes. The list is very long, so it's really, really important. Sometimes if people have some symptoms, that's another reason that you should get your eyes dilated. You don't have to wait till you're 40. If people have diabetes, that's another reason to get the eyes dilated. And I would also urge people to have family members. If they have eye melanoma, it's important to have your family members get a dilated eye examination. For example, I have a patient. Her daughter was found to have a choroidal nevus when she got her eye dilated, and then her sister also had one, and then her grandchild also had one. So it's just really, really important for people to, get their eyes dilated to look for nevi, which could be potentially precursors of melanoma. So there's some clinical features that we use to figure out is this a melanoma in the eye or not. It has a certain shape, kind of a dome or a mushroom shape. It could be pigmented, which is most common, but about a quarter of them are unpigmented. Often there's a retinal detachment associated with it, and often some orange pigment or lipofuscin. So these are some pictures. You can see a pigmented melanoma on the left. The upper right, you see a non-pigmented melanoma. And the lower picture shows a patient who had a pigmented nevus, and then it developed into a melanoma, which was mostly non-pigmented. Now, eye melanoma has actually several things that mimic it. So it's important for the ophthalmologist to try to distinguish, is this eye melanoma or something that just kind of looks like eye melanoma. So you can see some of these pictures can be a little bit difficult to distinguish. We also have to distinguish it from other tumors that might originate outside the eye. So for example, we might have a lung metastasis that travels to the eye. And so we have to tell, is this a metastasis or is this a primary tumor of the eye? These are some more pictures of metastases. So you can see how difficult it is to distinguish these things. So really we do a lot of testing to make sure that, what is this? Is this really melanoma? So I think photography is one of the things that you probably all experienced. Another thing, one of the most helpful tests is ultrasound. Ultrasound uses sound waves to help measure the height, the size of the tumor, and also to help confirm whether it is a melanoma. So this is an example of the B-scan ultrasound. On the left picture, you can see it looks, this tumor has a kind of a mushroom shape that is very characteristic of melanoma. On the right, you can see the center of that bump there has a very dark color. That's called acoustic hollowing. And what that means, it's pretty characteristic of eye melanoma. And it means that the cells are just very densely packed and very homogeneous. And that's why it looks that way. Another important part of ultrasound is the A scan. So on the left picture, that's the B scan ultrasound. And between those two white arrows, that's the area that has the low internal reflectivity on the A scan. So those little spikes there on the, those little spikes here are a low height in a melanoma, whereas in a nevus, they would be very high. Okay, so low in melanoma and high in nevus. So that's another thing that's very helpful. Fluorescein angiogram is another test that we might use. We would inject this fluorescein dye. It's a vegetable-based dye. We inject it in the vein in the arm. And the dye basically travels up to the eye, blood vessels, and we take a lot of pictures. And eye melanoma has a pretty characteristic way of how it looks, so that can also be helpful in making the diagnosis. You also may have heard of OCT pictures. OCT is a picture that uses light, kind of like ultrasound uses sound, and it makes a picture, a cross-sectional view of what we're looking at in the eye. So we can use that to detect the subretinal fluid, which is right here. And sometimes even MRI can be helpful it has certain properties in melanoma. All right, so next I'm going to answer the question, what is a nevus? That's a pretty common question. And so a nevus is a freckle. You might have heard called a freckle. It's a proliferation of melanocyte cells, and it can be found in the choroid of about 6% of people, maybe up to 10% of white people. And if we think of it as a precursor for eye melanoma, so just like colon polyps can be a precursor for colon cancer, you could think of a nevus as kind of be a potential precursor for eye melanoma. And we have to follow this over time. The thing is, nevi very rarely turn into eye melanoma. So one estimate is that about 1 in 8,000 will become a cancer. Another one shows age-adjusted risk less than 1%. So we try to figure out what are these more high-risk nevi. And these are just some pictures showing why we have to follow patients with nevi. Some, in the top picture, you can see the original nevus on the left, and over 13 years, only after 13 years did that change and start to turn into a melanoma. And in the bottom picture, you can see this on the left, only after a year did it grow and become a melanoma. So we have to observe. This is one of my patients who initially presented with a small lesion, and after 1 year grew a little bit, so we were able to detect this as a very small melanoma. Unfortunately, small melanomas are pretty much practically impossible to distinguish from atypical nevi. That's a very difficult diagnosis. And I think the Shields group in Philadelphia has been very successful to popularize this mnemonic device to try to find small melanomas early. Okay, that device is to find small ocular melanomas. So we look at the thickness. If the thickness of this nevus is more than 2 millimeters, if there's subretinal fluid, if the patient's having symptoms, or if there's orange pigment, or the margin of the tumor is right next to the optic nerve, that suggests it's probably a small melanoma, or at least those are risk factors for the tumor growing. So these are some examples of tumors that are atypical nevi but maybe suspicious for small melanomas. So in the upper picture, you can see where I pointed out some of the orange pigment that's present, and you can also see some of the subretinal fluid there. The lower picture shows orange pigment in the margin of the tumor right next to the optic nerve. So these are suspicious tumors. If these nevi don't have any of these high-risk characteristics, then very few will grow, only 3%. But if they start having some of these characteristics, then a higher percentage of these will grow. And so it's been suggested that we could actually consider treating these, even if we're not sure if they're a nevus or a melanoma, we could consider treating them at a very early stage when maybe people have 2 or more factors. Okay? So that's kind of a more aggressive approach, but it's the way to treat these kind of at the earliest stages. And why do we want to treat this when they're small? Well, one is we have preferable treatment options. We can use the radiation treatments rather than enucleation for small melanomas. Also, there's a better prognosis. So this is a little quote from this paper from the Shields talking about metastasis in 5 years is much smaller, about half that of what they consider the medium and the large size melanomas. So if we can catch this early, that's what we want to do as ophthalmologists. So what are our treatment options for uveal melanoma? Well, we kind of already talked about that a little bit earlier. So radiation is one of the most common and probably the most preferable treatment. And we have either the brachytherapy plaque, or we also have external beam radiation. Another big option is enucleation, and it's a very important option as well. And there's another option that you might have heard of called transpupillary thermotherapy. That's considered kind of controversial, and I'll just mention that briefly. So brachytherapy, I like to think of that as a radiation patch. It looks kind of like a bottle cap, and we sew that to the outside of the eye over the tumor. It has excellent 5-year survival, and the overall incidence of recurrence is low, maybe up to 10%, but probably generally lower than that. And often we'll use an ultrasound at the time we put that plaque on to try to make sure the localization is really good, and that potentially may reduce the risk of recurrent disease. Sometimes doctors will laser after this treatment is done as well, and that's another option. Probably about half of ocular oncologists will also do laser called transpupillary thermotherapy. This is a picture of what one of the plaques looks like. It looks like a bottle cap, and you can see here it's placed over the tumor, and there's a radiation oncologist who actually calculates to make sure that the tumor gets enough radiation to kill it. Another option that you might have heard of is proton beam radiation. This is also good for small and medium tumors. It has some potential advantages for tumors that are in the optic nerve, around the optic nerve, or in the macula. But sometimes it can have a higher rate of neovascular glaucoma complications. And the main point here is that very few centers have this technology in the country. It's extraordinarily expensive. I think our institution was looking at building a center, and it's about $300 million just for this center. So extraordinarily expensive, very few centers have this. Enucleation, we talked about, is permanent removal of the eye. This is the best treatment for large-sized tumors. So if the tumor is maybe larger than 10 millimeters in height and larger than 16 millimeters in the basal dimension. And what we do is we place an orbital implant here, and sometimes we attach the eye muscles to that. And we also, it's really important to get an ocular prosthesis. So you can see some pictures of the prosthesis there. So this is a patient. She's a 90-year-old white female who came to me, and she had some flashes in her vision, maybe a big shadow. And we could see on the fluorescein angiogram the typical hot spots and leakage that are consistent with the eye melanoma. And you can just see from the picture the large size of this tumor. And so what we did was we did an enucleation because it was just not really going to be treated well with brachytherapy. And she's doing very well after her enucleation, does not have metastatic disease at this time. So transpupillary thermotherapy, I'll just mention this briefly. This is a laser office procedure that we can do for small uveal melanomas. I would say most ocular oncologists feel this is controversial. Most of us feel that this is actually a less effective treatment than brachytherapy. It has a higher rate of recurrence. So most of us are not doing this for sure for most patients. And also, the reason why we might think about doing it is we might not lose as much vision as with the radiation. But in a small study by Dr. Harvard, it looks like the vision rates were actually fairly similar with brachytherapy. And this picture is just showing you can have some tumor growth or recurrence even in the area that was treated with this laser. So how do we know what treatments we should use? Well, this collaborative ocular melanoma study is one of the most important things that our country has done. It was an NIH-funded study, and it really was designed to figure out what management options should we use. So this was done in the 80s and 90s. They had over 1,300 patients, many centers throughout the United States and even Canada. And so we compared those two treatments, and what we found was that survival was the same. So we could actually have the same survival with doing either brachytherapy or enucleation therapy. So it was a very important study. And in terms of the visual acuity after brachytherapy, they found that most people did have vision that was blurrier, but they were kind of able to walk around. It was good enough to see to walk around with this vision, maybe read some big headlines. So I think it's a really important study. And I'll just take a minute to say that I think that it's really important that we continue to have research funding, especially for eye melanoma, because we're not going to progress and progress in this field and have better treatments unless we do that. So another question is, why do we do enucleation for large tumors? Well, if we try to do brachytherapy for large tumors, one problem is that there's a higher risk of treatment failure for those large tumors. And the second one is that those large tumors require so much radiation that the eye really doesn't survive well after the radiation. Usually it would become maybe blind and painful and would have to be removed anyway. So that's why we typically recommend enucleation for large tumors, although sometimes we can do brachytherapy as well. These are some pictures of eye melanoma at different sizes. And in terms of the mortality, the collaborative ocular melanoma study found that at 5 years, the small tumors only had 1% melanoma mortality. The medium-sized tumors had 10%, and the large tumors had 30% mortality. And so I think that was also important data from the COMS trial. I think this is an important question. Why don't we treat all atypical nevi, which are tumors with uncertain behavior? Well, I think one reason why ophthalmologists do not treat all nevi is that vision is precious, and the treatment will cause vision loss. Another reason is that only a small percentage of these nevi patients have melanoma and will develop metastatic disease. And in terms of even more benign-looking nevi, there's a very, very low rate of transformation of the nevus into a melanoma. So I think that's a question a lot of people have. Why don't you just treat all nevi with laser? And I think that those are some of the reasons why we don't do that. This is a question I think is on a lot of people's minds about uveal melanoma biopsy. You might have heard quite a bit about that. One of the main reasons that we would do a biopsy of an eye melanoma is if we have an atypical case. We're not 100% sure is this really an eye melanoma or is this something else. So that's one of the main reasons we do it. We use a very fine needle to do that biopsy. But actually now, we are really changing how the whole field is being managed. And we're actually now biopsying tumors at the time we put on a radiation plaque. And this is a controversial thing. You know, a lot of ocular oncologists are recommending biopsy, and there are many who are not. So this is a really new, big change in our field, and you'll hear a little bit more about this from some of the other speakers. I'll just talk a little bit more about it. Recently, I conducted a survey of other eye ocular oncologists and to see if they were doing biopsies and for what patients and why. And about 72% of them had obtained biopsies for molecular genetic testing for patients. So actually a pretty large number are now doing at least some biopsies. It is controversial. Some people will not want to do it because it actually, brachytherapy is considered a relatively non-invasive procedure. We're working on the surface of the eye, but we never enter the eye, or stick anything in the eye when we do that procedure. So now a biopsy is an invasive procedure where we do actually, enter the eye. And there's always some increased risk when we do that. So what are some of those risks? Well, it could be infection, severe infection in the eye, some bleeding, you can have decreased vision or even blindness. And what most people worry about is local recurrence of tumor. Okay, so maybe people worry about it could have the tumor come back after that biopsy. I think the risks of this procedure are pretty low, which is a good thing, but those are the risks that people would always, think about. One risk that people were worried about, and I think are not so worried about now, is that, does this biopsy increase the rate of metastatic disease? Okay, people were certainly debating about that at one time. I think Dr. Harber has showed some very convincing evidence that this does not increase the risk of metastatic disease. So he has done a lot of biopsies, and he looked at his patients before he ever started doing any biopsies, and then after he started doing biopsies. And the metastatic rate was exactly the same. And now we have a lot of centers that have done a lot of biopsies, and they so far have not found any increased risk of metastatic disease. So I think that's really important and really good news. So in my survey, I asked, for the ocular oncologists who did not like to do biopsy, I tried to figure out, what were some of the reasons. And the two main reasons were that we might get a biopsy result that separates the tumor into a high risk for metastasis tumor and a low risk. And most people who did not biopsy said they did not biopsy because there was no good treatment at this time, if you get a bad result. They also cited, the risk of the biopsy may be spreading the tumor cells around is their other major reason why they didn't do it. In terms of the people who did do the biopsy, the ocular oncologist said they wanted to do it to better screen to detect the high-risk patients. They wanted to identify patients for clinical trials because patients wanted to know the information, whether they were higher or low risk, and also for research. So I think this is it's a pretty new area. There's a lot of discussion here, and I think you'll hear a little bit more about it today. In terms of metastases, this is an area that needs the most work for eye melanoma at this time. After we detect metastases, survival time is low, and the sites we know already that it goes to are typically the liver, number one, but it can also sometimes go to the lung, bones, or skin, or central nervous system. So in our institution, I work a lot with Dr. Tom Olenke, who's one of our melanoma oncologists, and we've decided for the initial workup for metastatic disease to make sure whether we have any metastasis. We like to do a CAT scan of the chest, abdomen, and pelvis. We also do an MRI of the brain. And then if we suspect any liver disease, we might do an MRI of the liver. For follow-up testing, we try to do something like liver ultrasound, occasional chest x-rays. MRI of the liver has been suggested by some oncologists, but I think practically it's pretty difficult to get MRIs of the liver. For a lot of patients, some patients it's a very long test. It can be pretty terrible to be inside that MRI machine for a long time. It's also pretty expensive test. So I think, I think usually ultrasound of the liver is a very good way that we can follow it. Or if people have things to follow up on the CAT scan, so we did the first time, we might get a CAT scan again. Blood work is also helpful, although it's much, much less sensitive than imaging. But we typically get a comprehensive metabolic panel, which includes liver function tests and something called lactate dehydrogenase. So I think another good question is, why should I follow up with a medical oncologist as well as an ophthalmologist? Well, we talked about this before, that because the eye melanoma starts in an area that's basically a blood vessel area, it's kind of like the eye melanoma is already in your bloodstream, okay, even at a small size. And so some of those little cells will travel to the body, and they are what we call micrometastases. You cannot see them, but they're microscopic. And I think, they probably go to the liver and just lie dormant and don't do anything, and hopefully never do anything. I think our immune system probably helps control them. But we don't know, exactly why some would grow and others will just remain dormant. But because they're there, we need lifelong surveillance for detecting these if they would start to grow. So that's why we have to do it. And I think the frequency of your screening for this should depend on your risk factors. So what are the risk factors for metastasis? There's a bunch of risk factors that we know from pathology. So like the tumor size is really important. Also the cell type of the tumor can be important. The tumor is involving the ciliary body. That would be another risk factor. If a patient is older, that might be a risk factor. Or how fast the tumor is dividing. But I think now we have some genetic tests. This is one of the most exciting areas in the field right now, to find out, what is a high-risk tumor and a low-risk tumor. So in terms of genetic tests where we look at chromosome changes, monosomy 3 is one of the most important, and you'll hear a little bit more about this very shortly. But basically what that is, you lose one copy of chromosome 3. So I have circled up here, that's chromosome 3, and instead of the normal 2 copies on this karyotype, you only see the 1 copy. So that's one thing we're looking at. We can also, that's a karyotype on the lower left picture. The lower right picture is something called FISH, where we use fluorescent markers to look for, whether you have 1 or 2 copies. And there are other ways that we do these tests too. And we're doing some research looking at metastatic tissue and whether they have, monosomy 3 changes or other genetic changes, and trying to see if that would correlate with survival with metastasis. So I think if you have a normal chromosome 3 in the metastatic tissue, that seems to have a little bit better prognosis for survival. Another really important test is this gene expression profile test. This is based on RNA, so kind of gene expression is what we talk about. And you have class 1 or class 2 tumors. Class 1 is low risk, and class 2 is a more aggressive tumor. This is commercially available, and this is a graph from the Castle Bioscience website. So they're actually doing a prospective study and finding some differences, very significant differences in survival between the class 1 and the class 2. So we know for the class 2 patients, we want to follow class 2 patients very closely. There's also some other interesting genetic work that's been done. I'll just mention a couple studies. One is finding a couple different mutations in the tumor, such as GNAQ and GNA11. So people are looking at potential treatments that might inhibit these G protein mutations. And another really important one that you might have heard about is called BAP1, and that stands for BRCA1 associated protein 1. It's actually a new tumor suppressor that Bill Harbour found. And it's on that chromosome 3, so I think that's when people lose that copy of chromosome 3, this is probably one of the reasons why that's a bad prognosis, because we lose that tumor suppressor and we have more uncontrolled growth of the tumor. So people are working on this, and in terms of potential treatments, for kind of treating the BAP1 mutation. So we can see a lot of interest in this in our community of researchers. Baptism of a Tumor Suppressor by Scott Woodman. And our group has also been looking, like I mentioned, we're really interested in hereditary cancers, family history, and so with Dr. Abdel Rahman, we found, and actually with Dr. Hupland, we published this paper on actually a germline mutation of BAP1 was important not only in their eye melanoma, but also other cancers in the family. So lung cancer, meningioma, mesothelioma. So definitely there's a lot of research going on in this area, and to I want you not to feel alone. There are a lot of very passionate people. So for eye melanoma, we really need lifelong monitoring. There's been a lot of exciting developments in genetics, and our main goal we need to work on is better treatment for metastatic disease. There are some patient resources. I think more and more we're getting some of these. You probably are more aware of these than I am, but of course, the Ocular Melanoma Foundation, Melanoma Research Foundation is starting an pure ocular melanoma segment to it, so that's great. There's also something called the International Society for Ocular Oncology, so you can register at that website and get more information. And there's something called the Eye Cancer Network. They have a website also that has some good information on it. So I'd just like to thank everybody, and this is our group at Ohio State who work on eye melanoma, and we have a great group of people, and I'd just like to acknowledge them briefly. And I'd be happy to take any questions. So thank you.
Buckeyes.
Yeah, Buckeyes. Yes.
I'd like to give you an addition, another symptom that some people get, and that is eye strain.
Eye strain.
And eye strain is something that you cannot complain to anybody about except to an eye doctor.
That's true. That's true. I think that kind of goes along with the vision changes, the eye strain. That's a good one to add to that.
No, because it's not, for me, I had no vision change. My eyes just were totally strained, muscle strained.
Interesting.
But for that matter, I'm ciliary body,
Yeah.
which according to the information we've been given both last night and today is actually more muscle.
Mm-hmm. Yes. That's a good point. Thank you. Yes, sir?
My doctor didn't believe in biopsies.
Yes.
And so I've been discussing with him the efficacy of vitreoretinal. And he is of the opinion that after 6 months after radiation, where actually the tumor will necrofied, that it can still extract useful information as far as genetics is concerned.
Mm-hmm.
Now, he's an ocular oncologist, not an oncologist. So, is he wrong or is he right?
I don't think anybody has done studies to really test that idea. I think maybe some of the genetic changes you might be able to detect some of the chromosome changes. I think the gene expression changes. I don't think I would trust that test because the gene expression that depends on living cells. The chromosome changes, potentially you might be able to get some information about that, but we just don't know how reliable the information will be. So I think we just don't know. Yes.
Is there any point in having some of these genetic tests done after it's already spread?
I think that's a great question. So that's something that we're looking at it from a research perspective. So we've gotten some tissue after it has spread, and we looked at, so that, for example, for monosomy 3, we looked at GA2, GA11, like a bunch of different kind of genetic changes. And we did find an association with monosomy 3 and not all the other genetic changes we looked at. And we also found that there was more in the patients who survived longer with metastatic disease. There was actually more kind of immune infiltrate around their metastatic tumor. So I thought that was a very interesting finding because there's a lot of talk about immunotherapy for uveal melanoma and people working on that. And I think that that's something that we really need to focus on, whether we can use the immune system.
Well, I personally, when I was having things removed, I was saying, well, I don't want to just trash this stuff.
Yeah.
But my oncologist was saying, well, we don't have anywhere to put it. I mean, is there anyone who wants this material?
Yes.
I mean, who?
Yes, please.
Who? Where? How do you? Because if he had known who to give it to,
Yeah.
I mean,
It costs money to process the tissue
who
and to
has to
store
pay
it.
for that? I mean, is that
So basically, we have some donations or research money that pays for that right now. So when we do it at our institution, but if your institution doesn't have that money, then that's a difficult thing.
if you want it, it's at UVA.
Okay.
Just call the program.
All right, I appreciate it.
Can you help me understand the
Yes.
genetic part?
Sure.
You say there's a chromosome 3, a copy of it missing.
Yes,
Is it really missing or is it inactivated?
it's actually missing.
It's actually missing.
It's
So
actually
you
missing.
can't react.
But what we can see is, there is one, sometimes we have one missing, totally missing. Sometimes we have kind of a partial change in the chromosome, so it's not totally missing, but there's some changes in it. And then sometimes we have 2 copies of chromosome 3.
And those HDAC inhibitors that Dr. Harvey uses,
Yeah.
are they actually only applicable on if there's at least one present so that it can be?
We don't know that yet. We don't know that yet. So he has used that. The rationale for the HDAC inhibitors is based on the BAP1 mutation. So that's for the BAP1 pathway. BAP1 is on chromosome 3. So I think there probably is some overlap there. And I think, if the HDAC inhibitors look very promising for BAP1, I suspect it may be very promising for monosomy 3 as well, but I don't know that.
Yes. Is the orange pigment as important as the size in determining metastases?
I think the size is much more important than the orange pigment in determining the metastases. That's a good question. Yes.
And do you, as an ophthalmologist, do you follow up actually on the metastasis, or do you just have somebody that you refer them to, or are you even
Am I involved in that? That's a great question. So what I do in my practice is I do the initial metastatic workup, and then I partner closely with one of our melanoma oncologists. Or my patient cannot go to that particular doctor, then I would like them to go to a different oncologist that maybe is in their insurance plan. And I think it's really important for them to go to an oncologist. And that way, if a person would need to go to a clinical trial, I think that's a really, really important thing. I think for monitoring, I think they do a great job with monitoring for metastatic disease. So I always follow the tumor in the eye, and that needs lifelong monitoring as well. But I think I usually work with the oncologist. There are some other doctors who may not work with the oncologist as much, but I really like that. Yes.
I have a question about generations. I was under the impression that if 50% of your parents by a certain age had cancer, then 50% of their children will have cancer of some sort, just general, whether it's colon or wherever it may be. My question to you is regarding future generations, and for example, my niece has a nevus. She's had a nevus for probably 15. No, actually, it's not my niece. It's my cousin's daughter. But there's no relationship to any kind of cancer, but the nevus is watched from time to time.
Yeah, because a family member has an eye melanoma and another family member has a nevus, it doesn't mean the family member with the nevus is going to get eye melanoma, but I would have a higher degree of suspicion and want to follow them closely. So that's what I would answer to you. It does not mean they're going to get melanoma.
I agree. And a child in this same genetic next generation with vitiligo,
Okay.
who has somewhat of this orange pigment in the eye. Is there a possibility of anything going on there, or just wait and see, or monitor?
I wouldn't have enough information on that. I don't know. I don't know if the orange pigment is with a nevus or...
No, I don't know.
Okay. Well, I'll say, any weird thing in the eye definitely needs continued monitoring. And so that's the best advice. We need to be monitored by the ophthalmologist over time. Okay. I know I'm kind of ignoring. Yeah, go ahead. Who's next? Can you help me? Okay.
Do you offer biopsy before plaque?
I offer it to patients, but I don't do it for all patients. Yeah. A lot of my patients don't want it.
What was the question?
The question is, do I offer biopsy before a plaque? Okay. You, and then we'll go to the other side. Yes.
What is the prognostic factor of duplication of chromosome 3?
The duplication of chromosome 3, so isodisomy 3. So that's about the same as monosomy 3. Very similar to monosomy 3. Thank you. Okay, sir.
Can chromosome 3 be added back now or at some point way in the future? What's going on there?
That's a very interesting question. I don't think we can actually add back a whole chromosome. That would be really pie in the sky right now. But I think that people are trying to figure out what are the critical genes on chromosome 3, and then how can we use drugs like maybe HDAC inhibitors or something else, where we could protect from that loss of chromosome 3 that way.
And I'm sorry, follow up. If that was done, would that help with people who already have Mets? Or is
That's our hope. Yeah, we want to find something that works with Mets, and then take that to people who are high risk. Is kind of the usual way we would like to deal with that. Yes, ma'am.
If you didn't get a biopsy, what do we do?
Yeah. So I would say, if you don't have a biopsy, that's okay. I would say your frequency of how often you should be checked for metastatic disease will be based on our kind of traditional criteria. So if your tumor was a large tumor, definitely you need to be followed maybe twice a year by the oncologist. I think that would be really important. Or even a medium tumor, if it's a ciliary body tumor, followed more closely. And also the biopsy, the results are not 100%. So I think sometimes it can be frustrating because you don't get enough cells out to have a meaningful result on the biopsy. I had one patient who we did the biopsy and they were class 1, good prognosis, but he developed metastatic lung cancer, and he passed away from that. So it's not 100% kind of thing, unfortunately. So based on your traditional risk factors, you should be monitored based on that, is my opinion.
And I will also say the questions around genetic testing, the very next panel is actually going to cover a lot of that. So
yeah.
We can definitely dive into much more detail around when it should happen, what you can do if you've already had plaque therapy. That's what we're doing.
Anything else? I know we're running out of time, probably. Who's next? You.
Has there been any studies correlating drusen and macular degeneration with that being a risk factor?
There hasn't been any evidence linking macular degeneration and melanoma at this time. But the patients who get macular degeneration are older white patients more frequently, and those are the same kind of patients who are more at risk for melanoma. Yeah. Yes, sir.
Is there any frequency of it showing up in the other eye later on? Or I've never heard much about that. So
yeah, it's very rare that it would show up in the other eye or spread to the other eye from the body. That would be really rare. It's very rare. Yes, sir.
How many subjects have you ever examined that have a duplication amongst them?
The isodisomy 3, I haven't personally had any patients with that, but I forget the percent. The percentage is low, but it definitely exists. Yeah, so that's one thing in the genetic testing session. They can talk more about that. Yes.
Initial diagnosis. You listed out the risk factors. Headache involved in any of that?
That's a good point. Not typically. That's not a typical symptom. But was that something that
I have.
You have headache, and it was where? How to describe your headache?
Same side of the eye, running forward to back.
Okay.
You had it as well?
And did you have a ciliary body?
No, it was choroidal nevus. Started as a nevus and then became melanoma.
Okay. All right. Yeah, that's not a typical symptom, but it's good to add these to the list. Yeah.
I had that too.
Did you have the headache also? Okay.
Running up.
Same side, running up there.
Me too.
Sir.
With regards to having children, I have metastasis. I have 2 kids, 4 grandkids.
Yes.
When should they start the ocular
eye exam
check, the dilation? Is there a particular age? How often?
Yeah.
Because now I'm really concerned.
Yeah. I think that, probably by age 10, they should have a dilated eye exam. They can get it earlier, like 5 years of age would be okay. But certainly like 10 years of age is fine. Puberty will be the most important time. Make sure they get the dilated eye exam at puberty. Okay.
And then 30-year-old,
yeah.
should he be looking at this?
He needs to get a dilated eye exam. Once they have a good dilated eye exam, then they don't need real frequent monitoring. If everything looks okay, probably it's going to be okay. But if they find a nevus, they can just follow that over time. Yeah.
You say they don't need frequent monitoring. How frequent?
Well, in terms of a dilated eye exam, if you don't find any problems, like no nevus or anything like that, maybe every 1 or 2 years, probably 2 years would be fine. Yeah. Yes, sir.
With a nevus, how often do you need to examine?
I like to examine most nevi every 6 months, but if they're really tiny, maybe once a year.
is it a typical practice for like optometrists or even ophthalmologists to just not dilate if you're just going in for just your regular, routine eye checkups? Because, I mean, I haven't had my eyes dilated since I was a kid. So, and then all of a sudden I go in because I see flashes and there's like this huge tumor.
So I would say,
could I have caught it earlier?
I would say, sometimes, the eye care professional will not dilate the eye, particularly the optometrist. Maybe, you're getting your eyes checked, glasses at Walmart or, wherever your optometrist is. And I think the optometrists really are on the front lines of this. So, I really, for their society, they to do a complete exam, it does require a dilated exam. But they may not do a dilated exam. A lot of patients don't like getting a dilated exam because it's kind of inconvenient. Maybe the eyes feel funny or maybe uncomfortable, and it lasts a long time. So a lot of patients actually refuse to get their eyes dilated or just don't want it. So I would say, make sure that you ask, say you really want to have a dilated eye exam whenever you go in there.
What about clinical trials? What's the best place to find out about clinical trials for uveal melanoma?
I'm going to defer that to our oncologist because and actually Dr. Hovland may be talking about that too. So I'm going to defer that question to them later. Thanks. Yes, sir.
Going back to the dilated eye exam.
Yes.
Education-wise.
Yes.
The initial doctor you're seeing, how much do they get related to ocular melanoma?
Yeah. Ophthalmologists have more training, I think, for eye melanoma. Ophthalmologists, they go to medical school, and then get, ophthalmology training specifically for several years, see lots and lots of dilated eye exams, and the optometrist may not get quite as much training in that. So I think that certainly ophthalmologists have more training in that area.
Is there also more education for just regular dermatologists? Because of course I'm paranoid about everything, so I went to a dermatologist, and she said, and she's very, very well known in Dallas, and she said, this is what I was told. If somebody says that they have something in their eye, you have to send them to an ophthalmologist. That was the extent of her.
Okay.
So, I'm going and she's checking, but she knows absolutely nothing else. So when you're talking about melanoma oncologists, I'm wondering if I should be going, yes, go to a dermatologist, but as far as follow-up, who else do I need to put in my address book to make appointments with?
An oncologist is important. They don't have to be a melanoma oncologist. I'm just lucky that I have somebody that I can work with. If you see an oncologist, that's the main thing. And I would say I recommend the dermatology evaluation. I would say most ocular oncologists, it's pretty new information for them, so they may not recommend that, but I think that's helpful. And of course, your ophthalmologist is very important. So those would be the three on my list there.
And she's like, wow, you have a tumor in your eye? Wow. I mean,
you haven't heard of that? Right?
Yeah.
Going off of her question, with her dermatologist not knowing anything, is there a continuing education put out for physicians that would benefit from learning about it, such as an optometrist or ophthalmologist or even a dermatologist? Is there anybody that has published an article for them?
Right. So I think that's really critical. I think that I spoke last year for the Ohio Ophthalmologists Association. So I think most of the tumor people feel it's very passionate about it. We want to educate people as much as possible. So we're trying to speak at our professional societies. I spoke at the optometry professional society as well. We try to write papers. We need to write more papers. Maybe for the newspaper, we need to write some educational things. And I think as patients, you can educate your friends. Maybe recommend dilated eye exam to your friends. So I think we're just slowly getting there.
I think that would help. I think that would be very helpful. Yeah. I mean, there are many doctors out there that have no.
I agree. Yeah, no, agree. Thank you.
As far as monitoring for cutaneous melanoma, someone actually recommended to me, and I didn't even realize it was an option, and I had gone to a dermatologist before, to ask your insurance whether they cover mole mapping. A lot of insurances will actually do it, and they'll actually analyze them in a much more thorough way. So check with if you're interested in having that done, check with your insurance to see whether or not that's covered.
That's a good point. Some dermatologists now have these full body pictures that you can get that actually can map out your moles and kind of follow them over time for high risk things. So I think most insurances, unfortunately, do not, at least in our area, do not really cover that. But that's a good point. See if your insurance would maybe cover that.
Is there any risk factor with having low vision? Does your vision, and you have to wear glasses or not, but does your vision increase any risk factors with that?
Your vision has not been found to increase any risk factors except for if you have some vision changes related to like a nevus or something like that, then that maybe would push us to treat that earlier.
So like a nearsighted versus a farsighted person, there's no correlation?
No, not that we know of. Yeah, good question. If you have any more, if you're interested in contacting me later, I'd be very happy to talk with you or email or something like that. So